I'm Bob Falcone, CEO of the Columbus Medical Association and affiliates. Today, we have a panel of experts to discuss the long-term sequelae of COVID-19 infection, also known as the COVID long haul syndrome. Our next panelist is Dr. Kevin Johns. Dr. Johns is an assistant professor of psychiatry at The Ohio State University Wexner Medical Center and a co-director of integrative medicine. Dr. Johns is particularly interested in the psychiatric dysfunction of chronic illness. Dr. Johns, welcome.
Thank you for having me.
As you know, we're talking about COVID. Let's start with the inpatients. What are you seeing with the COVID inpatients, whether they're seriously ill or moderately ill?
Yeah, so, with the inpatient consults that we're seeing, unfortunately, there's a pretty wide range of neuropsychiatric sequelae that they're experiencing. Some of them, unfortunately, are developing, pretty severe delirium or encephalopathy, where they get really confused and might forget where they are, hallucinate, things like that. We've also had patients become catatonic. We've had patients who've developed other neurological issues like seizures or strokes as a complication of COVID in the hospital. And then on top of that, there's also the psychological impact of being hospitalized with COVID and being isolated from, all your friends and family. Unlike other illnesses, when people were hospitalized for COVID, they couldn't have any visitors. Even, the doctors and nurses had to gown up in PPE and, protective gear to go in and see the patient. So it's a very isolating experience. So, I think on top of the, the delirium and, other neurological complications, there's also, the psychological impact of the isolation and the fear of having a new disease that, people are just learning about.
Is the delirium different than the not uncommon ICU psychosis we see with seriously ill patients?
I think it is. In my experience, the patients with delirium, they tend to take longer to kind of reboot or kind of recover from that delirium. So I've seen, patients who are in the ICU with COVID, and even long after their respiratory status is normalized and all their other COVID symptoms have gone away, the delirium is just really persistent. It won't go away for a while. So it tends to linger much longer than delirium from other causes, in my experience.
How do you treat these people?
So, treatment is, similarly to, other types of delirium. We try to correct the underlying medical problems if possible. In many cases with these COVID patients, it's already being done. Their respiratory status is already improving, but we try to look and see, are we missing anything? Is there a urinary tract infection or something else that can be contributing? We do a lot of environmental modification, making sure their sleep-wake cycle is normal, trying not to disturb them at night, friendly, familiar faces during the day. And then, there's also a role for medications as well, and delirium. So we do use medications to help with some of these symptoms too.
Tell me about the strokes. Those sound unique to COVID.
Yeah, it's unfortunately, many COVID patients have developed kind of hypercoagulability syndromes and develop strokes, and that in itself, can lead to lots of neuropsychiatric sequelae.
I imagine. Let's switch to the people that are not hospitalized, but a week, 2 weeks, a month after they've had their COVID episode and recovered, they have continuing sequelae. What are you seeing there?
So we're seeing a pretty broad mix. A lot of things. Some patients develop kind of worsening of pre-existing mental illness. So, for example, if they already had depression or anxiety after getting COVID, it can get worse. We're also seeing patients with new onset diagnoses after developing COVID. So, no previous history of depression, but then they get COVID, and afterwards they, develop a depression or anxiety disorder. Some patients can develop, PTSD or PTSD-like symptoms from, being cared for in the ICU and surviving a critical illness. We're also seeing, quite a few patients who have these kind of cognitive complaints where they feel like they just can't focus quite as well as they used to. Their memory is not as sharp. So even after all the other symptoms have gone away and they've gone back to work, they find that they just can't perform cognitively at the level that they used to. Those are some of the things that we're seeing.
I would assume that you treat depression like you would treat any depression, but tell me more about these cognitive dysfunctions. I've heard them called brain fog. What do you do for them?
Yeah, it's it can be very devastating. It can be hard to diagnose, hard to catch. So we try to screen these patients early on, and then we try to refer them to our neuropsychologists. We have a group of neuropsychologists here at Ohio State who are doing cognitive testing in patients who are recovering from COVID-19, and they're helping to develop individualized plans to help them recover cognitively.
Kind of like brain rehab or occupational therapy and some of the other modalities we use for other people with the same kind of symptoms.
Yeah, exactly.
Most of these people are cared for in primary care offices. When should the primary care physician be concerned about some of these psychiatric issues, and when should they ask them to see a psychiatrist?
That's a good question. I think there's, unfortunately in the field of psychiatry, there is a huge shortage of psychiatrists in the community. So oftentimes, primary care, they are the first line of defense, and and referral can be really challenging, especially in more rural areas of the country. So um, that being said, I think anytime that the symptoms, fail to respond to therapies that the primary care provider is comfortable with using, like for example, common antidepressants. If there's concerning symptoms like concerns for mania or suicidal ideation, self harm, these kinds of things, it would be a good idea for the patient to be referred to a higher level of care.
That makes complete sense. So if they're comfortable with antidepressants and the patient's depressed, that seems to be reasonable. If they have opportunity to send people to occupational therapy or neuropsychiatric cognitive evaluation and therapy, then that's probably a good bet for some of those symptoms. How about people that are just have continued lassitude and fatigue and weakness? Is any of that psychiatric overlay, or is that more physical?
I think anytime with these, when patients with chronic illnesses, with difficult to explain symptoms, optimizing their mental health is a critical part of their recovery. Similar to, for example, patients with fibromyalgia or chronic fatigue syndrome, having a robust mechanism in place to screen for things like depression, anxiety, substance use, things that could be contributing to these symptoms is really important, and then having a way to get the patients to treatment.
So it sounds like things that most family doctors are doing now. They're treating the whole patient and making sure that everything is as good as it can get before they get down and dirty on the psychiatric issues. Does that sound about right?
Yeah, yeah. The depression and anxiety, they can basically, worsen outcomes in virtually any illness, that they're paired up with. So, anytime that you have these chronic illnesses, whether it's things like fibromyalgia or diabetes, optimizing depression is always going to be something that could go a long way in helping the patient recover, especially when it's something where there's not like a quick treatment to, cure the illness or make it go away.
In your experience, do most of these people get better? And if so, how long does it take?
That's a good question. I think, it's probably a little too early to tell right now. I think that story is still being written, as we speak. I would expect that, some of these people will get better. My concern is that some of these patients may develop more long-term symptoms, and there's going to be a lot more research and coming down the pipeline to figure out how to help these people.
Well, this has been great. Is there anything we've missed?
I think I would just, echo that, the most important thing at this point is to take a holistic approach, treat the whole patient, like we said, here at Ohio State, whenever a patient is discharged from the hospital after being diagnosed with COVID-19, we have a transition of care group that reaches out to the patient, and they'll screen the patient for depression, anxiety, And then if they screen positive, we can enroll them into a collaborative care program where the internal medicine doctor can collaborate with the psychiatrist and the social work care manager to treat the patient in a team-based approach. So, having creative ways to screen and rapidly identify, the psychiatric symptoms in patients with COVID-19 or recovery from COVID-19, I think is going to be really important in the long run.
Great. This has been really informative. Thank you for your time.
Thank you.